And I love hormones. I love talking about hormone replacement. I want women to be healthy. And so this talk for me is very, very special because as I enter into my own aging frontier, I'm 55 years old, I see so much in my practice of, should I take estrogen? Shouldn't I take estrogen? And my mother had breast cancer, or my sister had breast cancer, or what should I do? And are hormones okay for me? And if I decide not to take hormones, what do I need to do to prevent against breast cancer? Because we all know that by the time the mammogram actually picks up the tumor, it's been in you for 8 years. So the talk tonight that I put together, I think is really good because it goes into estrogen itself, some of the brand new literature. What I did on the slides is everything on here. There's a reference on each of the individual slides, so you can check those references, and everything is current. The latest I try to go back is maybe 2 or 3 years if it's got a little bit of a review paper in it, and I think it's got cool info. But everything here is really current. So I wanted to talk about really what we can do as practitioners using this amazing technology that we have to make our patients feel comfortable if they're on hormones so they're not panicked about breast cancer. The last few days in my office, I've seen like 4 or 5 women that have breast cancer. You know, women take so much care of everybody else, and then all of a sudden, boom, they get this diagnosis, and now they're in a panic state. So what can we do to keep them healthy and minimize recurrence? And then what is the appropriate way to just maximize health in the long term and look at prevention as far as overall well-being? So I like to start every talk with a quote, and estrogen and hormones and breast cancer have been a huge challenge, but I definitely think with the right focus and technology and integrating everything together, which is what I'm going to do for you tonight, is really going to help make a difference in your practice, and really what I hope reassure you in what you do when you start treating patients with estrogen, or if you see somebody that comes in with a history of breast cancer or a high family history of breast cancer, as far as what can they do to minimize their chances. And while we know there's BRCA testing, and we know there's Lynch syndrome, and we know that some women have a hysterectomy and don't have a hysterectomy, I've been in the OB-GYN space for 25 years. What I'm going to talk about tonight is really true info about hormones and some of the old info that's been refuted as far as estrogen. What really, from a microbiome and aging process, predisposes you to breast cancer? Not, oh, I'm cooking along my merry way and boom, my mammogram shows a malignancy. And then testing we can do to really optimize not only hormone balance, but hormone offload. And then what evaluation and supplementation we can do, and certain techniques to really help with prevention. So the first few slides I want everybody to see shows where estrogen is really significant. Women feel bad off of estrogen. They get a big drop. Menopause comes, estrogen tanks, and women just don't feel good. So there's a couple studies here in understanding how important estrogen is to the overall female aging process. First study here, very recent, shows how low estrogen levels are just directly associated with short telomeres. And we know shortened telomeres are associated with aging, with poor aging. So more than any other factors out there, short telomeres are an issue, and low estrogen is associated with that. Number 2, when your hormone levels dysregulate, you don't sleep. When you don't sleep, when estrogen and especially progesterone are gone, you're up all night. You may fall asleep, and then we get that classic, oh my God, I'm up from 1 to 5 or 1 to 3, and I don't feel good. I have hot flashes. And what you find is that there's an effect on the genes that actually dysregulate the immune system when you can't sleep, and boom, you move on to aggressive aging. There's tons of literature now about how Ambien and Lunesta and those sleep aids aren't sleep aids, they're actually sedation aids. And what happens is that when you take those, you're sedated. You don't sleep. And when you don't sleep, you have epigenetic problems, and that's why those drugs are actually associated with an increased risk of cancer. So it's not necessarily the drug that's a problem, it's a false state of sleep. Number 3, what they did here is they took old monkeys, old mocks, and what they did is that they fed them our typical Western diet, right, this more obesogenic diet. And as these menopausal monkeys, if you will, ate their typical diet, weight went up. Well, when they gave them estrogen, what they found is that activity increased, less anxious behavior showed up, anxiety decreased. Again, they moved a bit more and their weight went down. So what they're finding is that adding estrogen to an aging however you pronounce that, monkey, really made the monkey healthier. As we get deeper into the understanding of this, look at what this says. It says the development of obesity with metabolically unfavorable fat redistribution is observed during menopause caused by the hyperandrogenemia in the conditions of lack of estrogens. So you drop estrogen, you increase your androgens, you don't feel as good, boom, weight changes. And even if you see, I see a lot of patients that are even fit. They're still exercising, they're still doing the best that they can, and they go, man, why am I getting this gut that I never had? Why don't I feel as good? Here's what happens with estrogen in the brain, right? Brain changes, free radicals become a problem, all kinds of new literature about estrogen drop and Alzheimer's, and 3-to-1 Alzheimer's in women. So we know how valuable estrogen is here. Here's where they talk about cardiovascular disease, that heart disease, and I know there was a lot of controversy with that Premarin study, but these are brand new papers that talk about when estrogen is present, you're going to see a healthier state of being. And then last but not least, your skeletal muscle. So when you look at the aging muscle and the aging bone, estrogen makes a big difference. You get less free radicals. You repair better. Estrogen is a true antioxidant. So using estrogen in the aging process of a female appropriately is something that I think is going to resurge again. We're seeing more and more hormone replacement therapy. I use a lot of bioidentical replacement, and then women want to feel better, especially as we age better or longer. And if you think about it logically, right, if you hit menopause at 50 and you're going to live till 90, that means you're going to spend half your life without your hormones. So it's important to understand what we can do by understanding what's going on in the aging female body, what changes in the gut, and what we can do to actually maintain health while minimizing any kind of cancer, and especially in this case, breast cancer. So this is interesting. If you read this, WHI reported in publications that in the 16,000 women that they looked at back in 2002, that it says a combination of estrogen and progesterone, the risk of breast cancer increased. I'm sure almost everybody on this call realizes that there's a very big difference between the progesterone molecule and Provera. Provera is medroxyprogesterone. You can see the side chain that's changed, and this goes down the more potent or toxic estrogen pathway. A lot of new literature now about birth control pills and depression, and birth control pills and breast cancer also because of the medroxyprogesterone. So it's almost comical, though, that when the study comes out, they turn around and they will interchange those words. And it's sad because now what happens is even the OBGYNs will say, oh, they'll use Provera and progesterone interchangeably. So understand that we want to separate out that estrogen isn't necessarily a problem. And look at this slide, 2017. Although a significant reduction in breast cancer was seen with Premarin, the conjugated estrogens, a significant increase in breast cancer was seen with the progestin. So it's the medroxyprogesterone that really was where the study needed to focus. And even the statistical significance of the study is being called into question. So estrogen isn't the evil that we thought, but it does go down some bad pathways in the detox pathway. So the crux of what I want to talk about in this study is how if you give estrogen and you give progesterone, how we maintain health in the patient, what studies or what testing we can do to maintain health in the patient so that they can be very comfortable taking both estradiol and progesterone. And I personally use estriol, but you'll see that that doesn't turn into the toxic estrogen, so I'm not going to really focus on that as much. It's more the offload of your estradiol, testosterone, and a little bit of progesterone that we know will help, so we want to keep down the healthy pathway. And if you look at the end of this study, I think this was 2016, physicians should have no hesitation prescribing natural progesterone, micronized progesterone, that it does not cause breast cancer, it's actually protective. So a couple minutes about what's going on in the aging female body and brain and ovaries and gut, where estrogen dominance becomes a problem and where we can intervene. So, right, health span is genes and proteins, but the surrounding environment that the cells bathe in, right? That's our epigenetics. And so anybody that's ever seen a talk that I give might have seen this slide because I think it's a great explanation of just DNA. So think of your DNA as Mardi Gras beads wrapped around spools of thread. And the key to health span is closing these spools of thread together that actually have bad genes in them. So methyl groups, or that carbon-hydrogen group, will actually pull those histones together so those bad genes can't be transcribed, and then it will also separate, the acetyl group will then come in and separate out the good genes. So this enables us to only fold good proteins. So methylation turns off bad genes, very, very significant in detoxification also. So again, we inhibit transcription with methylation and we activate it with acetylation. So where do we come up with those methyl groups? Well, you can't methylate if you don't have the methyl or the carbon-hydrogen group from your green leafies. The darker green, the better. Well, if you don't have the nutrients to process, so the folate comes from your green leafies, so the enzymes with using your B6, your serine, your mag, all your other macro and micronutrients, the one that you have to make sure you're taking in, will be needed so that MTHFR, and I'm going to get into that enzyme a little bit, can actually spin the wheel so that the carbon, hydrogen, or methyl group is given to SAMe, and then SAMe can take it where it needs to go. I'm going to talk a little bit more about MTHFR later. Right now, I just want you to understand that detoxification of everything, including your estrogen, happens with the liver and the gut, but it is phase 2 of liver detox where methylation happens. So that MTHFR is going to generate that spin in that wheel, and SAMe is going to come over and go from phase 1 to phase 2 detox. If this is done efficiently, the less favorable estrogen byproducts will be offloaded. They will not be available to circle back to the breast, to pound on the tissue to create the changes that predispose to breast cancer, right? Because think about it. Once somebody has breast cancer, what do? They remove as much of the cancer as they can, and then they give tamoxifen. The oncologists give tamoxifen. They're not changing what's going on in the body. They're just blocking the cell receptors at the level of the breast. So it's like when you tell people with money, well, you could either make more or spend less if you're running into money problems. So therefore here, we either methylate more efficiently, get our gut working, or we have to pile more drugs into the patient. So if we can improve microbiome and improve methylation, then what we can do is we can decrease the amount of bad estrogens. So remember, cholesterol plus B5 plus carbon chains come together to make all of our hormones. And we know that cholesterol is fat soluble, right? It's oil. So the way that you're going to offload is to poop or pee, especially the hormone byproducts off. So it is in the liver that you have to go through phase 1, phase 2 detox, and that's exactly what's going here. So your hormones turn all into estrone, and you can see where the estradiol turns into that. And most everybody has seen this offload. You will either make the 2-hydroxy, the 16-hydroxy, or the 4-hydroxy estrone component. Well, the problem is that 4-hydroxy is extremely carcinogenic. The 16 turns into estriol. You notice there's a question mark around it because some people say there's a little bit of controversy about how aggressive the 16 is. But I'm going to show you at the end of this talk a great test that I use now, a great urine hormone test that looks at a 24-hour urine and really gives us good parameters of where we want to be to make sure offload is reasonable. So we want to decrease the 4-hydroxy, but even if we make it, we want to increase COMT. And we may have a mutation We may have nutrient deficiencies that I'm going to discuss, but the big take-home message is to get that 4-hydroxymethylated and out of the patient. And when you do that, you will minimize breast cancer and minimize recurrence. So that's 2 minutes back on menopause, and this is really important. Perimenopause and menopause are not related to just the exhaustion of ovarian follicles, but a failure of communication between the ovaries, brain, and pituitary gland. This is so important to understand. The classic medical school practitioner, anybody is taught follicle-stimulating hormones tells the ovaries to make estradiol, and then when there's a negative feedback, the estradiol increases, the FSH drops. So therefore, when the ovaries fail, the FSH elevates, and that could not be further than the truth. And I laugh. I go, man, I learned that 25 years ago. There's nothing new since then. What actually happens is that the central nervous system telomeres shorten and control on the ovary decreases. So what you find happens is that as you hit your 40s, the ovary will start to make more estrogen one day, less the next. That's where the irregularity comes from. Otherwise, everybody in their 40s would have the same perimenopause. You wouldn't have, oh, this lady's bleeding really heavy, and this lady needed a HIS, and this one needed an ablation, and this one says I'm okay. It has to be variable. So the ovary, which has a mind literally of its own, is kept in control from when it's controlled in teen years through about the early 40s, when it loses connection, connection to the central nervous system, and it starts to do whatever it wants. This is really important because most people relate FSH to menopause. Look at the numbers. The connection or the dysregulation happens as early as in late reproductive years. So you can see that start to scoop up as early as your late 30s and then into your early 40s. Well, when that happens, you're going to start to see this estrogen dysregulation. So estradiol and progesterone are low when you're born. Teen years, the ovary wakes up. Central nervous system controls everything. Progesterone, you can see in the purple line, kind of maxes out. Boom, that's perfect childbearing. Now at 40, the ovary does whatever it wants. Well, you can see where if you can't methylate, if the liver detox is a problem, if the gut's off, and you've got spiking levels of estrogen, and you send them down the wrong pathway, they're going to go back and chronically stimulate the breast, and that's where you're going to get that predisposition to breast cancer. It's pretty black and white. What happens is that if you think about it, breast cancer takes 8 years. 8 years from tumor nidus to actual showing up on mammograms. So if you're diagnosing women in their early 50s, late 40s with breast cancer, when is it starting? Boom, right as you hit into your 40s. So it is that dysregulation that is starting this process that we need to look at. So what you do, and I set together a good process of what you can follow to see where your patient is. So now you look at the FSH, but you're looking at the follicle stimulating hormone more in terms of where is their tightness. Meaning if you see an FSH that's like 2 or 3, you know that the communication between the central nervous system and the ovaries is still pretty good, and your chance of massive estrogen dominance is not so bad. As it starts to spike up to 10, the disconnect can start, and again, that can be as early as late 30s, early 40s. Those women, depending upon some of the other parameters we're going to look at, you're going to find predisposition for breast cancer because now they have offload problems. If they have offload problems in the light of some spiking estrogen, then you have to be more aggressive looking at that. And then when your FSH really starts to elevate, it doesn't mean there's no ovarian estrogen. It means there is no or minimum connection. So an FSH that is elevated over 20, that LabCorp or SpectraCell or whoever you use, and SpectraCell does a great panel. When you see that number over 20, it's, even though it's common postmenopausal, it doesn't have to be. So the numbers aren't super literal. You will see why here, when you get your regulatory hormones from SpectraCell, you get your estradiol. So an elevated FSH with an estradiol that registers means that she is still making some ovarian estrogen. And you'll see the same thing when you look at the luteinizing hormones. So just because those guys are not in the menopausal range, or because they are in the menopausal range doesn't mean that you're not going to make estrogen. You check your prolactin, make sure that the pituitary gland is in line. Very interesting, elevated prolactin can come from free radicals. I've had a bunch of patients that have an elevated prolactin. They get an MRI, they have this little prolactinoma, they get that removed, so somebody cuts their head open and their periods still stay irregular. So I think that you find gut issues and inflammation issues, and that's going to create pituitary issues that will throw your prolactin off. But often when you fix the gut and you get the body back in line again with the nutrients, the prolactin will normalize on its own. Sex hormone binding globulins, remember, they are linked to blood sugar dysregulation. They will elevate with birth control pills, they will elevate with estrogen dominance, and they will lower less than 35 when you have blood sugar dysregulation or metabolic syndrome. So they're a good barometer of where your patient is. They're rising high, take a look at her estrogen because she may be struggling with estrogen dominance. Same thing with thyroid. As estrogen dysregulates, what happens is sex hormone binding globulins will elevate to keep the estrogen balance. So it's going to pick up the free hormones, and what are you going to start to see? Low free T3, low free T4. So the patient now doesn't feel good. Her detox is a problem. She's 45. She's got a little bit of estrogen dominance, and you check her thyroid. That's why you check the whole panel. You have to rule out antibodies to make sure that she doesn't have Hashimoto's or inflammation problems. And I could do a whole talk on thyroid, but remember, if you have thyroid antibodies, it's a disease of inflammation more than necessarily just hypothyroidism, and Hashimoto's needs to be looked at, and antibodies need to be looked at from an inflammatory viewpoint. Reverse T3 will elevate because the body says something's off. So when you see a reverse T3, optimal, you'd like it between about 10 and 12, but if you start to see it elevate, and even though free T3 and free T4 are low, that patient is not hypothyroid. And if the gut is off, which I'm going to show you what starts to happen as you age, as the gut microbiome dysregulates, it will stimulate the thyroid. So you can see this TSH that's high normal, and a low free T3, free T4, still in range, but you'll see an elevated reverse T3. Before you start treating that patient, please go ahead and start looking at estrogen dominance, gut microbiome, and metabolic balance. I added this because I learned so much from Jim Paoletti. Here's a link to his talk and his info, and we use this in our office and quote him, that, give him credit, but patients can see this. And then what you do is you can do their thyroid, add it onto this sheet, and show them where their gradient isn't balanced. And so you want them running basically around the 1.3 or lower in the free T4, and you really don't want somebody in a high free T3. You want 3.1 or lower. Look at their reverse T3. Please remember, Mother Nature would never be dumb enough to have us live hyperthyroid. It is impractical. Hyperthyroid creates free radicals, high cost of doing business, and you get into trouble. So get the thyroid balanced and check out where your hormones are. Methylation and dysregulation of the gut, if you get that in line, that is the biggest thing you can do to prevent breast cancer. 3 things that we got to worry about here. Enzyme mutations, right? MTHFR, which I'll talk about, that can be mutated. Gut dysregulation is going to slow this cycle spin. And then nutrient deficiencies, and you can't spin this. And they all become a vicious cycle. You have a mutation, and then you can't turn the wheel as well if you don't compensate for it. Remember, we don't treat genes, we treat problems. So leading in MTHFR, somebody's diet is off, they're working the night shift, they're stressed through their life is crazy. So what happens is boom, they can't spin their cycle as efficiently to keep up with their life. Then what happens is they don't make choline as well, so they don't line their gut as well. Now they can't absorb their nutrients. Now the methylation cycle slows even more. Now we get nutrient deficiencies even more. And with the lack of the methyl group to be used for liver detox, boom, now we've got elevated 4-hydroxyestrone, and we're headed down a breast cancer pathway. You can check MTHFR deficiency or mutations or SNPs through SpectraCell. The 677 mutation seems to be related to the homocysteine wheel or the SAMI wheel more than the 1298. 50% of the population has a single 677 mutation. Just because you have a mutation doesn't mean you need to pile methylfolate on people. Please do not do that. Test the micronutrient deficiencies, because I can't tell you the amount of people that say, oh my God, I have this methylation problem. I have this variation in this gene, and so I'm on all this MethylGuard and all this folate. And then you give them all this folate, they'll get a B12 deficiency. If you don't give them enough B12 or you give them too much B12 folate, then they'll get a MAG deficiency. So it's important maybe that they understand, hey, you carry this gene. I tell people it can't be that bad, right? Or we'd be dead. So clearly if your body's functioning, the mutation isn't that bad. But if you strain the system and then you become estrogen dominant and your gut's off, boom, that's where you get into trouble. So please use this so they can have an awareness that they need to be confident or cognizant is a better word, of understanding what they need to do for their own health. In other words, they need to be part of their own health. All right, so here's the right side of the wheel, right? The B12 folate's coming in. We have to make SAMI. We got to take that methyl group and take it all over the body. Three main things that are going to spin this wheel, give you wheel spin problems: cortisol dysregulation, free radical problems, and gut dysfunction. The studies here aren't all related to breast cancer because I found some studies just more powerfully related to methylation. So I thought this was interesting. Cortisol dysfunction show that pregnancy anxiety is associated with DNA methylation problems in newborns. The number one most methylated part of a female body in the case of pregnancy is the third trimester placenta. You need those light bright pegs, those battleship pegs, those little pegs put in the right place so that the correct genes turn on and turn off to make that baby. So you can imagine if an anxious mom is affecting the placenta and her baby, what it would be doing to your detox. And people, you know, it's interesting. They'll get the 4-point cortisol and they'll go, oh, my cortisol's a problem. And yeah, there's supplementation you can use to help that, but there's a whole slew of things out there: meditation, emotional freedom technique tapping, binaural beats, grounding. There's so many things that you can do that actually help cortisol. So people don't want to do that sometimes, unfortunately, because it takes time. You know, give me a pill, I'll get it better. So they have to understand that they have to look at their life and look at their day-to-day and minimize this cortisol dysfunction, especially if they have MTHFR mutations. Second thing is free radical overload. So here is where they develop. Basically, free radicals, as we know, is our cost of doing business. It's life on Earth, and it is going to happen just existing. But when your muscle works, you make free radicals. Well, you need to exercise, but you're going to make more free radicals. So what you want to do is understand, well, if I'm a little slower methylator, or I am nutrient deficient, and that's going to slow my methylation cycle, then because I'm going to make these free radicals, I have to make sure that's in place. And should I have mutations in MTHFR, and later I'm going to show you COMT, then I'm going to be worse in phase 2 detox, which means I'm going to have more backup in my bad estrogen pathway. Last but not least, microbiome diversity. All right, so microbiome diversity gets worse as you age, and through your aging process, it has to be watched through diet, right? So the findings of this study showed that maternal diet from mid to late gestation can shape again the baby. So if that's happening in women and that's affecting the baby, what do you think it's doing to methylation in our own body? So guts off, bugs are off, we don't methylate, and we run into problems at all levels. Number one thing that affects your gut microbiome is plant rotation. So things you can do, your patients can do to control, at least in their own day-to-day, is rotate their plants. This came right out of Rob Knight's University of California, San Diego microbiome project. And I thought it was interesting. Exercise, sleep, alcohol. Nothing is more important than plant seasonal rotation. And a lot of people go, okay, I had, say, steak with broccoli. Tell them buy a lot of a little. Buy a little broccoli, a little Brussels sprouts, a little of the red peppers and the yellow peppers, and make a big vat of that, convection roast or wherever you want to make it, and eat that at night and leftovers the next day. So the more you vary your plants, the better. Please print this out and show it to them because most people just don't get it. Okay, so now I'm trying to do everything possibly I can right. Problem is that as you hit perimenopause, like we talked about, your control from your central nervous system and your ovaries weakens. So what happens is you start to get estrogen spikes. When you get those estrogen spikes, you're going to have to work harder to offload more estrogen. So your gut microbiome is going to have to work harder. Well, the problem is that gut microbiome diversity decreases with aging. And what happens when you actually take the ovaries is what happened in this study. So this was done in Fort Collins by a PhD there. And what they did is they took high aerobic capacity, real fit mice or rats, and then less fit rats. And what they did is they took the ovaries out of half of them. So they all went through surgery. Half lost their ovaries, half didn't. And then what they did is they looked at the microbiome in the ones that didn't lose the ovaries versus the ones that did. So sham means I got anesthetized, I got cut open, my ovaries were left behind. So I went through the trauma of surgery, but what happened is I got my ovaries left. The OVX means I lost my ovaries. And then what they did is they looked at the short-chain fatty acids. So remember, 4 things keep your gut massively intact, healthy: choline, glutamine, cholesterol, and short-chain fatty acids. Those are the things that are on the cell membranes keeping the gut lining healthy. So look what they found. The fitter you were, so that would be the high aerobic capacity, the better you held on to your short-chain fatty acid production, but it didn't matter. They all went down relative to the ovaries that stayed behind. So when you don't take estrogen or estrogen starts to fluctuate, you're going to start to lose intestinal control of the ability to make your gut healthy. So now a bunch of different things are going to happen, right? You're going to not be able to offload your estrogen as well. You're not going to be able to absorb your nutrients as well. Now you're not going to methylate as well, so you're not going to make as much choline because you make choline with methylation, and now you're not going to be able to repair your lining. So should your glutamine be low, an essential micronutrient, you can't make your choline as much, and now you can't make your short-chain fatty acids because your microbiome is changing. You're in a lot of trouble. These two now are icing on the cake. So what they did here is they looked at people. They looked at perimenopausal and postmenopausal men and women. And what they did is they found that the more diverse your microbiome, so the more observed species or the higher your Shannon index. So your Shannon index stands for the bunch of different bugs around. The more diverse you were, the more you peed off. So you can see the y-axis is estrogen in the urine, and the x-axis is microbiome diversity. So the more you pee off, which is a good thing. Now, the more diverse you were, the less that was in the stool. So the less diverse you are, the more that stays behind in the stool to be recycled in the enterohepatic circulation to now be sent back into the blood and back into the tissues to create an estrogen upload. So it's kind of like that old-fashioned water wheel. In other words, instead of flicking it out to the Mississippi River, you kind of rotate it back into the local lake. And so now what's going to happen is you're going to wind up with more estrogen floating around. So it's a complete inverse relationship. And look what happens now as we get deeper into menopause. The inflammatory cytokines, boom, go through the roof. And look what happened when they gave estrogen. So everybody goes through menopause, and then what they do is the cells, and you can look, it says oophorectomy and subsequent estrogen therapy on all these inflammatory cytokines. So boom, 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 they get higher, and then you get estrogen back, and they go down. So what you're doing is you're creating more inflammation, and the whole system's falling apart. So the kind of this worst spot, which would be those perimenopause, early menopausal years, the woman is really struggling. And what's really a shame about that is that that's when she's going, well, maybe I don't need it. Maybe I can live without it. So at the worst time, when she really needs the most support, that's where she's really going to run into most trouble. So it's important that she understands that estrogen, we get a good history, and we don't villainize estrogen, but we say, wait a minute, here's what we can do to help you minimize risk of breast cancer. We're going to check your MTHFR. I'm going to look at where your hormones are. I'm going to maximize your thyroid. Then what I'm going to do is I'm going to look at the other things around you. I'm going to make sure you methylate. I'm going to talk, and I'll explain a little, and you're going to talk to her about COMT mutations. You're going to make sure her liver's detoxing. You're going to minimize her oxidative stress. You're going to check her MAG levels, and you're going to make sure her micronutrient deficiencies are not significant, so her B6, B12, and folate are there to do what they need to do. Now, COMT, remember, is that, and I re-pulled the estrogen offload up at the end, COMT is what takes phase 1 detox into phase 2. It takes the 4-hydroxyestrone, which is that toxic estrogen, into the 4-methoxy, which is benign. It also, it's interesting, is very significant balancing and dopamine and serotonin in the central nervous system. If you have a VALMET mutation, if you have a single SNP in the COMT, you can have as much as a 40% drop in how it balances estrogens and central nervous system. And the reason I bring up dopamine and serotonin is somebody that comes to you that says, man, I had bad PMS. That usually means when they had that big hormone surge the second half of their cycle, especially in their early 40s, they probably didn't have a great COMT or great COMT support. That's where their PMS came from, because their dopamine and serotonin was balanced. Assume they're a little bit of a detox problem and focus on that. Do you have to get the mutation? Sometimes I do, sometimes I don't. But if you look at the estrogen offload and you look at urine estrogen or salivary estrogens and you see that elevated estrone, you know they may have a COMT mutation. But what's most important is that we just support it. And here's where just the literature talks about that a functional single SNP can actually decrease the COMT function by about 40%. So just realize that it can be there. And what we've learned is that it is B6, B12 folate supported. So if you give that patient, even with the SNP, and make sure that their B6, B12 is therapeutic in their micronutrient test, and even push it a little bit, then what you'll find is you can actually push the COMT to kind of step up its game. And here's where it is. You can see where the 4-hydroxy offloads to 4-methoxy using COMT, and you'll also take the 2-hydroxy and you'll help the offload there. But it's just really significant to push that carcinogenic pathway to the 4-methoxy. And some women actually have that CYP1B1 mutation, which means they will aggressively push to that 4-OH. So you can imagine if you have a CYP mutation that's going to push in that direction, and even a single MTHFR and a single COMT, kind of what your setup is. You're sort of a disaster waiting to happen. So what we can do, which is really cool, is if we can get your nutrients in line and get your gut microbiome optimal, then what happens is we minimize your chance that you are going to potentially develop any kind of breast malignancy. Okay, now this is what I've found recently with urine hormones. I use this offload test. There's a bunch of different urine hormone tests out there. The reason I use this particular one is that it gives me data of where optimal place to be. If you are treating someone with hormone replacement, or if somebody is coming off of breast cancer, or if they're estrogen, worried about being estrogen dominant, this is really cool because it's a 24-hour collection. I've spoken to a lot of different PhDs, and the thing you worry about sometimes with spot collection is if you spot collect at noon, but the bigger offload is at 3 o'clock, or the biggest offload is through your sleep cycle, you can miss the amount of what you're actually peeing off in your bad estrogen if you do a spot urine. So this is actually a representation of a 24-hour urine. And you can see what's really cool here is you can look at estrone, but you can look if you have a patient on hormone replacement. Where I think this is great is you can then not only get therapeutic levels of your patient so they feel good and you're protecting their bones and protecting their brain, but look, you can make sure that their 4-hydroxyestrone is low. And I think this is invaluable for patients that have a family history of breast cancer, for patients that worry about breast cancer, and for all patients on any kind of hormone replacement, because what you're doing is you're maximizing their health while you're minimizing their risk. And now you can say to them, look, whether if she's not on hormones, you can say, look, your levels are low, and if she's had breast cancer and she's worried about a recurrence, then what happens is you can say, look, your 4-hydroxy is reasonable, your 2-hydroxy, which is the good guy, you're offloading without a problem. We'll talk about micronutrients. Those guys are where they need to be, and boom, you're good, and the lady feels better. I'm using this a lot with the micronutrients for patients with mother who has breast cancer, because they get into their late 40s, and 1 in every 6 mammograms gets a callback. Number 1 cause of lawsuits for radiologists is mammogram problems. So those poor radiologists are panic stricken. So you get somebody who has a mother with breast cancer that gets a callback at 48 years old. I've in my career had to talk them off the ledge. They're panic stricken. So they'll do this once every couple years. You get their micronutrients in line, you run their urine hormones, and now they feel human when they go to get evaluated. So it's a way that you can really do their nutrients and make sure they're good where they need to be. So get them in place and then say, look, your offload is great. And so I think that's an even better look than a mammogram. Not that I'm anti-mammogram, but man, by the time they call me back and do that biopsy, I've had cancer in me for 8 years. And here's where now the micronutrients come into place. You check the baseline, you follow the patient every 4 months, 8 months, 6 months, kind of you make your judgment once a year, whatever you want to do. And here's where the big deal with the SNPs are. Don't treat the SNP, treat the patient. So look at whether she's low in folate. She doesn't need methylfolate if she's methylating plenty with the MTHFR that she has. So check their nutrient deficiencies, invaluable. I use SpectraCell's cardiometabolic test for breast cancer patients. I use it for everything. They call it CardioMet. They should call it, kind of a be-all, end-all, because here you can look at, are they low in DHA? So can they spin that methylation wheel? You can look at, are they a blood sugar problem? If they're a blood sugar problem, they got to have microbiome problems. So even without doing any other testing, you say, look, your fasting blood sugar. I see a ton of people, their A1C will be okay, but their fasting blood sugar is 103. That's a digestion gut problem. Now she's perimenopausal, she's going to have offload problems. So you can work on that. What's really cool too is you can look at their total cholesterol. So you want optimal cholesterol, 160 to 190, 195, but suppose she's got that and she's got particles. Well, why would you have LDL problems in a normal cholesterol if you weren't porting that cholesterol out as an antioxidant to do something? So you can use the cardiometabolic test to look at all of that. And then on top of that, you can look at leptin. You can look at C-reactive protein. So you can look at parameters that will maximize her metabolic state to maximize everything else. And here is where you can look at dysfunction in everybody. Low cholesterol, you get less than 160, and you can't fix your brain. You can't make cell membranes. So that becomes a problem. You can work on digestion. Leptin, you start to see leptin over 15. I think SpectraCell says 21 or 25 is a problem. You have a woman that complains of weight gain and her leptin is 15 or 18, you know that you got to start to worry about metabolic issues. C-reactive protein, again, is there an inflammatory issue? Fasting insulin, optimal 4 to 8. You start to get above 8. Yeah, they call it diabetic, but from a functional viewpoint, you want somewhere between 4 and 8. And so you'll see somebody maybe that's got leptin out of control, and they'll have their C-reactive protein elevated, and now you can look and you can say, well, your insulin's elevated also, or sometimes even if you have an elevated C-reactive protein and you have a high leptin, sometimes the liver has moved to stage 4. It said, man, I can't even keep up with this. So you'll see they'll have a normal glucose and a normal insulin, and you're going, how is that possible? Because the system is so blown apart that you're finding here that the body's given up. So you can work on the gut, work on digestion, and get the system back in line again. It's going to help their overall health and will definitely help their breast cancer. You can look at fasting glucose, and I've just given you optimal levels here. This is what you want to look at for real health and prevention. This book, and here's kind of coming to the end, is written by a guy named Avram Blooming, and I recommend everybody that does any kind of hormone or estrogen or protection, probably everybody, every woman should read it. And basically, what Avram Blooming, Dr. Blooming is an oncologist, and his wife developed breast cancer at 47, and she had chemotherapy and lost her ability to, she lost her ovarian function. And this lady was miserable, and he ripped apart everything, ripped apart the studies. Prior to the WHI 2002 study, Premarin was the number one hormone prescribed, or the number one pill prescribed in the United States. I think it was higher than Lipitor back then. And then, boom, it tanked. So you have to turn around and say, was somebody, did that study give somebody, line their pockets with some kind of money because why its stock went down? He gets into all of that, and he'll talk about even the WHI study. It wasn't hugely statistically significant. 2 years later, it came out that it wasn't statistically significant at all. And when they follow those women today, the women that were on hormones less died of breast cancer. It's a great read. He'll tell you that even Premarin isn't terrible. So I think it really puts things back in line. And he talks about a lot of institutions out there that are even doing info on giving estrogen back to breast cancer patients because it's really not that bad. And I'm not saying to do that, but I'm just saying we have so many things that we can control that if we control that as the patient hits the perimenopause, menopausal years, we can help women age well. That aging space is completely empty. And the problem with the OB-GYNs, and I'm an OB-GYN and I did it for a million years, is it's so hard because they're so worried about babies and the robot and hysterectomies that they can't read into this. And I think it's the practitioners that really understand functional health that can really help the aging women, and I think that's what they're going to be looking for. So as good old Bill Gates said, right, treatment without prevention is unsustainable, and we have to start from day one. To me, mammogram is really treatment. It's saying, hey, you got a problem, we got to do something. So I think true prevention is going to go back to what can we do to look at as the female body is changing to keep them as healthy as possible. So I hope this helped a little bit, and I hope the slides help a little bit to help you help your patients. Please feel free to print them and use them to help your patients. And let me know if I can answer any questions.
Thank you, Dr. Ginsberg. We have a few questions that have come in. Question number 1, can you give an example for prescription for menopause HRT compound?
Yeah, so very interesting. I've been an A4M member for a long time, for probably about 15 years. I started with my own journey with learning and my kids and fell in love with functional medicine. And what A4M does is they use saliva. And that's what I used for a long time. And I still use it quite a bit to look at patients in general as far as where their detox is. I think because of the WHI study and salivary testing, they tended to be very estriol focused. So the, hey, you're menopausal, the 80-20 estriol with 20% estradiol was sort of the go-to. And I think what I've found as I've done my own research and talked to the lab guys, the lab PhD guys, and especially the urine hormone guys, if you run the 80-20 dose early in menopause, and I'm not even sure with later menopause that I'm still with the 80-20, you're not going to make that patient feel well. So what I usually do is I run their nutrients, and I check their FSH, and I do their basic hormones. And as long as their estrone is not super elevated, meaning they're a terrible detoxer, I'll start them at a 60-40 or a 50-50, where the 60% would be estriol and the 40% would be estradiol, and the 50-50 would be, say, 50% estriol, 50% estradiol. You can start a little more potent there, and usually look at the patient. I use between probably 1.1 to 1.2 milligrams per cc, half cc, so start them at about maybe 0.5 to 0.6 is the dose that they're getting in the bi-S combo. Now, let me tell you a quick interesting story, and because I love this stuff in case you can't tell. So I had a patient come to me somebody who had her on 5 milligrams of bi-S. And I was like, oh my God, her urine hormones are going to be off the roof. She'd been using this for maybe 5 years. When I did her urine hormones, she was still in the low red. In other words, she still wasn't therapeutic. So the compounding guys tell us how absorbent this is, but I wonder if the skin, we use it on the underarm or on the inner thigh. So what I've been doing is I'm still kind of using the thigh, but I've been starting to move to vaginal application, and I think Jonathan Wright does that now. The mucosa really makes a big difference. Not using an intravaginal, because nobody likes that, but just rubbing it vaginally. So what you can do is you can see kind of where their absorption is. Start at that dose, like between 1 and say 1.2 or 1.4, which gives them between about 0.5 to 0.6 or 0.7 of the bias combo, and then check them maybe urine-wise in about 4 to 6 months once their symptoms are better. And then if they're not rising and you don't see reasonable levels, start using a little bit vaginal, use the mucosa, and then you can play with that. And if you find that you're using intravaginal or mucosal absorption and they're still not in that therapeutic range, push them to the green range, and then you can see where you have the offload. And I think we're going to start using higher doses than we think, because we need to protect the bones and protect the brain. And saliva, the numbers I think are a little bit too low. They show up too high. They're a little too overrepresentative. So don't be afraid to push those levels.
Okay, our next question. Which micronutrients do you expect to find abnormal in women with risk factors for breast cancer?
That's a really good question. And you know what? I think that there's going to be no prophylactic of that, because I think then you could put a protocol together. Because I think that the methylation wheel that I showed you is a simplified wheel, but if you really look at it, you're going to see that there's MTR puts the B12 with the folate, and the ACHY puts the MAG on. So I think you also don't know what their other life is. Like there's a great lady that I race a triathlon, and there's a great lady who's had ovarian cancer twice, and she does Ironman. So who knows where she'll be, because she's burning her methylation all over the place. So I don't necessarily think you'll see the B6, B12 folate low. I think it's just variable. If you have somebody that's got a VDR BSM mutation, they're going to have more inflammation in their gut when they eat gluten. So you're going to find that they're going to shred their gut more. So you may see them more choline, glutamine low, and now as they're perimenopausal and they're running into breast cancer risk, their problem is more from their gut offload than anything else. So I wish I could come up with an answer for that, but I think you just got to test. You just got to test and look at them and just replace what you see.
Should a normal, healthy woman who's through menopause use estrogen and progesterone for better health?
Absolutely, 100%. Because what does through menopause mean? Through menopause means she's not complaining as much of her hot flashes. But what happens is that Alzheimer's is coming and bone density is coming. And if you look at the first 10 slides in this presentation, you can't age well. And I've explored all of that. And I've looked at the NAD and the nicotinamide riboside and the TH. I mean, I've looked at all that stuff. And everybody's arguing what's the best thing to do for aging. I don't think there's anything as good for the aging female as estrogen. I have women that come to me at 65, 68 years old, and I restart them. I start them low. If you listen to some of the gurus in hormone replacement, they'll tell you that once you've been 10 years out, if you give them a big burst right away, so that person start low, maybe like 0.5 milligrams, half cc of the 80-20, maybe be a little more gentle if you're starting somebody that hasn't been on them for 10 years, and then bring them up to par. But all through means my hot flashes are better. She is going to have brain recall problems. She's going to have brain fog, and believe it or not, she has it. She's just not telling you.
Okay, next question. How long are you prescribing HRTs? Indefinitely, or is there a cutoff? How do you know the cutoff?
There's no cutoff. Indefinitely. I take bias, a little testosterone, progesterone, and a little DHEA. And at this point, I'm 55 years old. I've been on it for 3 years, and I'm going to take it forever. My mom will, until my grave day comes. But my mom went through menopause at about 55, 56. She was lucky. She was a little bit older. But I have a terrible gut, right? I was an OBGYN resident. One of the girls in my office sent me an article the other day that you lose 6 years of your life, your first year of residency. I mean, it kills you. So your system blows up. So to me, I went through menopause younger. There's all kinds of literature about how you are healthier when you go through menopause older. I can't imagine why I would ever stop. So for me, I would keep patients on it indefinitely, absolutely.
Okay. Do you worry about clotting risk factors with estrogen therapy?
Not if you use it transdermally. The amount would be minimum. Do I think you need to check a factor 5 or any of that? No. Even birth control pills, when you think about it. I mean, I can tell you, watch what'll happen to me now, but knock wood, in my 25 years of practicing straightforward OBGYN, I don't think I had one DVT in a young kid. Not one. I had one blood clot, I think one DVT in a hysterectomy patient, but not one in a birth control kid. So I just think it's really very, very rare, and transdermally I would not worry about it, right? Because what happens is when you take estrogen orally, the first pass effect, the reason you get the clot is because the proteins that are used in metabolization of the estrogen are the same proteins that are used in the clotting cascade. So that's where your problem comes from. So the unclot gets disturbed. So and when you start to look at the patch and the ring, the problem they're just high levels of estrogen, almost like when you start to look at pregnancy. That's a different animal. But when you're looking at replacement, the reason it's an issue is oral estrogen. So don't give it oral, don't give it sublingual, don't give it in any way. The people say, oh, sublingual, it's not. Pam Smith, who I learned so much from American Academy of Anti-Aging, she will tell you estrogen and testosterone have to be given through cream. You do not want it to go through the gut or the liver, and then you do not have to worry about clotting.
If a woman had a full hysterectomy and does not want hormones, could phytohormones be sufficient?
Could what hormones? Biohormones?
Phyo, Phyo.
Oh, phyto. No. And here's really interesting. Like, I have a patient that comes to me and says, well, my practitioner gave me natural progesterone cream. That's what the phytohormone is. It may have a little, and I shouldn't say no, probably not. But it may have a little bit, like if you use chasteberry or you use certain natural components while somebody is going through a perimenopausal estrogen fluctuation, do I think that you can modulate the fluctuation? Sometimes with phyto support, possibly. Certain companies make those products. I think almost any of the good vitamin companies will make different, perimenopausal estrogen modulating products. Problem is that they do not sit exactly on the receptor, because if they did, you would need a prescription. So, like, for example, I have a lot of patients that say I use progesterone cream. I think, if I'm not mistaken, digenin is what is the actual natural, what comes out of the what they use to make the progesterone. You can't mush that up and turn it into a cream and rub it on and use it. It's almost like, remember the Sex and the City where Samantha, they're flying to UAE and her hormones get taken and now she's freaking out, and so there's a picture of her in the bathtub like with yams on her face. It just doesn't work. So you need a prescription to actually take a hormone. So somebody that's had a complete clean out that has no estrogen, the phyto stuff may modulate a little bit here and there. I've not seen anything effective. Where I've had a little bit of results is somebody that really is just estrogen high, estrogen low. They're in their perimenopausal years. You don't want to treat them yet because you give them estrogen and then they spike, then they're bleeding all the time. So sometimes you can use that there, but Young Living makes Progestis Plus, and it has to be, anything real needs a doctor's prescription behind it. So can you try? Absolutely. Do I think you're going to have any real results? No. And if her flashes pass with time, you're not getting estrogen levels into her body where you're doing anything for her bones and her brain and her Alzheimer's.
Okay, last question. What are your thoughts on testosterone replacement and no estrogen replacement?
So I follow the professors that I learned, and I've learned so much from A4M and Pam Smith, and she sent us a bunch of articles because people ask about this all the time, and they'll tell you that if you give somebody high doses of testosterone without estrogen, they'll plaque. In other words, you have to balance them. So I would not recommend that. I'm not judging what people do. You have to be very careful with the pellets. I don't use them. I think when you start driving levels up like that and you don't put the person back in balance, right? The whole concept of hormone replacement is to make somebody, I tell people 49 and a half, right? Make them that until they're 125 when their telomeres wear out. So your key there is to have them feel better, minimize oxidative stress, get their brain working, keep their muscles where they need to be. So if you're treating somebody, you're treating them. Now, I'm not a breast oncologist, so I know that there are some studies out there where high doses of testosterone were used, and I can't remember who did this study. I heard Jennifer Landa do a talk once, and she quoted this research lady. And so I'm not talking about that. This lady was using high doses of testosterone to help with breast cancer patients. That's not what I'm talking about. I'm talking about the patient who is basically pretty healthy, menopausal, and turns around and says, I don't want to use estrogen, but I have no libido. Would I treat her with testosterone? No, because big part of her libido and her sense of well-being is estrogen. So I'd get her balanced, and I'd run that urine test, and I would show her that she's okay, and then I would bring her into balance.
Thank you, Dr. Ginsberg. We are actually out of time for any more questions. Oh, go ahead, Dr. Ginsberg.
I was going to say my pleasure, and I hope this helps.
Have a wonderful evening, everyone.
Thank you. Thanks.